Hi, Rosman. Welcome to the CTO&CHIP PCI, courtesy of Rosman. I'm honored to chair this session and to introduce our distinguished speakers. We've got an interesting session here. I'll introduce the speakers one by one. We've got 15-minute presentation with 5-minute discussion in between. So I think any of you are welcome to give your opinions. We're here to discuss some of the key instruments that will be exhibited today, which is your balloon, the pot balloon, the wedge, cutting balloon, scoring balloon, as well as your microcatheter, ProNavi microcatheter, and of course the LVO high pressure balloon. It's semi-compliant but very high pressures, operative pressures. So I'd like to begin by, of course, I thanked this earlier, the Rosman people for organizing this and our sponsors. And we'd like to, of course, welcome Dr. Han, who is a panelist and guest speaker. He is the MD Chief Physician, Master Supervisor, Director of the Second Ward of the Department of Cardiology, the first affiliated hospital of Zhengzhou University in China. And then we've also got Dr. Ajit Chandrakant Mehta from India. He is, of course, the consultant in cardiologist at Jahangir Hospital. Welcome, Dr. Ajit. Welcome also Dr. Han. And Dr. Mohamed Aymen. Dr. Mohamed Aymen bin Abdessalem. Welcome, Dr. Mohamed Aymen from Tunisia. And he is an interventional cardiologist at Farhat Hashed University Hospital Center and also at the assistant professor at our University of Sousse. Welcome. We have also from China, Dr. Zhong Xin, and he's an associate chief physician, Department of Cardiology, Zhongshan Hospital, Fudan University, and he's a member of the CTO Masters Club. And finally, we have our distinguished speaker from Dr. Jorge Guardado, I hope I got that pronunciation right, who is the head of cardiovascular intervention unit at Leiria Hospital Center, Clinical Program and Executive Director at Eucardio Clinical Center Cardiovascular Unit in Portugal. Welcome, Dr. Jorge. Is that correct? Is it correct pronunciation? No, Jorge, welcome. I'm not sure whether his audio is okay. Is Dr. Jorge, are you hearing us okay? Hello?
Yes, it's okay. Hello, I can hear you. Okay.
Okay, that's fine.
Now I'm listening.
Okay, thank you very much. So everyone is here on board then. We'll start the session with our first speaker. It's entitled Unblocking Life's Path Journey.
I'm not listening.
Can you hear us? Unblocking, the first speaker will be Dr. Ajit Chandrakant Mehta. Dr. Ajit, are you okay with this?
Yeah, absolutely.
Okay. All right.
Are my slides visible to you all?
Yeah, I'm clear. We can hear you quite well. I'll hand the screen over and the session to you, Dr. Ajit, for your presentation.
Yeah. So are my slides visible and am I audible to you all?
Yes.
Yes.
Yeah. Hi, everybody. I'm going to present a case of octogenarian male patient, history of hypertension, came to us with complaints of breathlessness on exertion, chest discomfort while walking, crescendo angina since last 2 to 3 months before presentation to us. ECG had global STD changes in all the leads, but more so in a V2 to V4. Had global LV hypokinesia on echocardiography, and ejection fraction was 25%. We took him for an angiogram. Angiography shows patient has had distal left main significant disease, large rim and occluded. There was a disease in the osteoproximal LAD, and circ was non-dominant and near normal. You could see, collaterals giving to distal RCA from the left system. And this is the right coronary artery, which had bridging collaterals. Proximal RCA was 100% occluded, CTO in a proximal segment. And this is the angiography of this patient. So looking at the angiography, 81-year-old symptomatic patient, ejection fraction of 25%. So, we gave all the options of putting him on a medical therapy because of his age, thinking about doing viability and then taking a further course of action. The viability showed there was significant viable myocardia in all 3 territories, LAD, RC, and circumflex. And then after this, we had a a heart team approach. We discussed the patient details, and then it was a surgical turn-down patient. It was a CHIP CTO. Syntax score was 37. The option was CABG versus multivessel PCI. EGFR was 61. Am I audible?
Yes, yes.
My internet connection. Yeah, sorry. We all know this patient comorbidities, complex coronary artery disease, hemodynamic compromise, but patient practically had everything from patient comorbidities, age, heart failure, unstable angina, except diabetes and prior cardiac surgery. He had all the risk factors from a patient comorbid this thing, complex coronary artery, multivessel, distal left main, CTO bifurcation, hemodynamic, severe LV dysfunction. So he practically had all the risk factor to say it was a CHIP CTO case. The plan was to do multivessel PCI with mechanical circulatory support, and because of the cost constraint, we chose intra-aortic balloon pump. And otherwise, also when patient was not in a bad LVF, patient was not on high inotropic support, generally prefer intra-aortic balloon pump for the cost constraint reasons also. And we thought we would do this case under intravascular imaging. This is a JR guide catheter with a Corsair support catheter. This was the Filter XTA wire. Filter XTA wire was not traveling the true lumen. It was all the time going into subintimal space. So, and there was no good support from the guide, so we had to change the guide to M+, which gave us a good support. And change the wire to Gaia second. So, it was fortunately not too difficult for us to cross the, CTO segment with Gaia second wire, park the catheter in the distal RCA, exchange it to BMW workhorse wire, did multiple balloon dilatation from proximal to mid RCA, and the proximal segment was stented with 338 everolimus dilating stent, post dilated with 315 balloon at 18 to 20 atmosphere. This was the OCT pullback, and this was the final result on the right coronary artery. So we got a good result on the right coronary artery. This was the OCT pullback. There was a good MSA. There was no proximal or distal edge dissection. Expansion and apposition was very good throughout the segment of the stent, and RCA looked very good. So after doing RCA, this is the post PCI RCA OCT analysis. MSA was good, expansion was uniform, more than 80% all throughout.
Nice.
Then we went to the left system. And then we went to the left system. Left coronary artery was fitted with 7 French XB guide catheter. Remus had to be crossed with Gaia second with the Corsair catheter, and wire was exchanged finally to BMW. So we had 2 workhorse wire, one in LED and one in Remus. Remus was the OCT run was taken from LED, and this was the OCT run from the LED. If we can see the analysis of the OCT, the distal LED was okay. MLA was 5.84, and there was some calcific nodule at the distal part of the left main or proximal part of the LED, which was later tackled with a cutting balloon. Remus was pre-dilated and stented with 2.515 everolimus dilating stent. We thought we wanted to be quick, a little quick in this patient. That's why we chose mini crush or DK crush in this patient. So Remus was stented with 2.515 everolimus dilating stent, 0.3 into 15 from left main to LED. Proximal side optimization was done, balloon was pulled back, and post-dilated at a high pressure. Stent was crushed initially with 315 balloon, and step crush was done with 3.5 into 15 balloon at 16 to 18 atmosphere. So this is the side branch optimization. This is the crush, and this is after doing crush of Remus stent. Then left to LED was stented using 338 everolimus dilating stent at 16 atmosphere. This was the result after stenting left main to LAD. Pot was done with 4.5 into 12 balloon at 16 to 18 atmosphere. So we did all the steps of mini crush and technique. Initial pot was done with 4.5 12 balloon at 16 to 18 atmosphere. Internet connection is a problem. No, it's okay. Then after doing pot, the crossing of the circumflex was the ramus was very difficult. After we did pot in the left main with the smallest profile balloon, 1.1 millimeter balloon, also crossing the ramus was very difficult. So we had option of taking 0.75 balloon, but more than that, as we had a corsair catheter on the shelf, because we had used corsair catheter, we thought we will use corsair to make some passage into the ramus. So this is how we use the corsair, made some passage into the ramus, and after that it was a simple straightforward kissing balloon.
We lost you there. Can anyone hear Dr. Ajit? We've lost Dr. Ajit. Dr. Ajit, we've lost you if you can hear us. And the slides frozen at the last angiogram. Hello? Dr. Ajit, are you still with us? Okay, never mind. While waiting for Dr. Ajit, maybe we can Dr. Ajit, can you see whether you can rectify the technical problem on your end while I open the floor to discussion? Can I invite the comment from, say, our guest panelist, Dr. Han from China, Dr. Han ZhanYing? Dr. Han, any comment in regards to the left main stem crush stem actually into the LAD left main and crush the ramus? Is there anything that you would do differently?
Yes, and nice to meet every one of you. It's my pleasure to be here to discuss this very interesting patients. And this patient is very high, 81 years old and with hypertension, and right coronary is CTO lesions and left main, and LAD involved the lesions, and so I'm very agree with his strategy to treat the right coronary first, and because maybe the CTO, the segment is not too long, and using the firstly he chose the guiding catheter, maybe the Jenkins. I'm not sure about it now. Then he changed to the AL, the guiding catheter. Yeah, increase the support and using the gear second guide wire and to puncture and through the segment of CTO and to the distal of the lumen of right coronary artery. Then and using one stand and recover the right coronary flow to TME3. Then and move on strategy to treat the left main and LAD lesions. So I didn't see the IBP. This patient, if you use the patient, because this patient he's cheap maybe, and maybe it's more safe, relatively safe using the IBP. But sometimes we just using the use the IBP standby and then to treat, and just to treat the left main and LAD. Maybe it's unnecessary to use the IBP because blood flow is okay for the LAD and the circumflex. But during the procedure, and Dr. Mehta made some difficulty to advance the balloon to the ramus through the metabolic mesh. But after the procedure part, and using the 4.5 balloon, then and maybe enlarge makes the blood cells become more large, and it's relatively easy and to advance to the balloon to the office of the reamers. So it's very it's an exciting and interesting patient, and so this patient will teach us some science, something, yeah, and some experience. So thank you for excellent cases for us.
Right, I agree. Excellent case, Dr. Ajit. You're back with us. Welcome. Any other comment from the audience? Perhaps I can invite the audience, the panelists, and the.
So I don't know where I don't know where I left you. Can I just complete? Can I show the last image of the angioplasty? I don't know where I left you actually.
No, I think you're shot.
I'll
The last
I don't know.
last shot.
So where did I? What was the last slide you could see?
You showed us a spider view of the prior to the angiogram. You put a balloon there. Yeah, before the kissing.
Yeah, so basically did report, difficulty in crossing the ramus, which we crossed it with Corsair catheter, kissing balloon, final pot, and OCT run was taken. OCT run, this is the image with the OCT run. OCT showed the distal LED stent was well opposed, good expansion. MSA was good. Expansion was more than 100%. But there was small, age dissection in the proximal segment of the left main.
We don't see it. We see the pot balloon there, but kissing balloon.
Yeah. So pot. Yeah. So there's some small age dissection in the proximal portion of the left main. So, but the rest of the parameters were really, comfortable. Then we went ahead, tackled the left main dissection with 4/8. Stain at 16 atmosphere, and report was done with the same balloon 4.5 at 16 to 18, and this was the final result on left main to LED and left main to ramus. This was before and this is after. This is right before and after. So it's been about 3 to 4 months. Patient comes for regular follow-up. His ejection fraction has improved to about 45%. Clinically, he is much better. Thank you very much.
Thank you very much. Thank you for a very nice presentation. I'm glad to hear that EF actually improved. That doesn't happen all the time, 22 to 45%. Any other comments from anyone else? We've got a few minutes more left for comments. The idea, yes, I agree with doing the right first is a very good idea. It helps. How many of you would actually switch on the balloon pump rather than keep it on standby in this case? Dr. Han mentioned just now that he probably might not switch on, but he would have it on standby. Would you switch on the balloon pump, guys? Dr. Jorge? Would you switch on the balloon pump for these patients and keep it running, one-to-one augmentation?
Hello, good morning.
Yes, good morning.
Hello, everybody.
Yes, I can hear you. Yeah.
No, I doesn't change. I just keep. I don't need balloon pumping to this case.
Right.
I think it's nice like it is, and the final result was very nice.
Very nice. I agree. Yeah. Any other comments, Dr. Aymen? Any comments from you? Would you do differently?
No, I agree for the RCA first. So it makes things easier. And it prevents maybe hemodynamic collapse in my experience. And in my experience, I don't have mechanical support. I don't use it for protect PCI. I usually for cases when I do a hemodynamic study and when I find things aren't good, I try to improve the situation with inotropes, IV. Right. And when the situation improves, I take the patient.
Yeah, fair enough. Can I just ask Dr. Ajit, maybe I missed it, your balloons that you used to inflate the lesions, were they a mixture of scoring balloons or mainly semi-compliant balloons? What was that choice of balloon? I didn't see any scoring balloons being used earlier.
Mainly, no, I think for the osteoproximal LED, we used cutting balloon because there was some calcific nodule which was seen on OCD, but rest all were normal, non-compliant balloon everywhere.
Non-compliant, okay, fine. All right. So, which brings us to thank you very much, Dr. Ajit, for the very nice illustration. Excellent results, by the way. Keeping the time, our next presenter will be Dr. Zhong Xin. Dr. Zhong Xin will talk about optimizing complex lesion treatment application of the Wedge NC scoring balloon. So now we have an opportunity to look at the scoring balloon from Dr. Zhong Xin's experience. Over to you, Dr. Zhong Xin.
Sorry, Dr. Rosman. The second one is Dr. Aymen.
Sorry, Dr. Aymen. Oh, Dr. Aymen, sorry. Dr. Aymen, you are the next presentation. Dr. Aymen bin Abdessalem will start the presentation on when connecting the knuckles is a must. Over to you, Dr. Aymen.
Thank you very much, dear Chairman. I would like first to thank Rosman for this kind invitation, for the opportunity to present and to share some cases. I'm Dr. Aymen from Sousse, Tunisia, and I will try to share with you some cases where I used the Pronavi microcatheter. So first case is a 61-year-old male. He's very active. He has diabetes. He's a previous smoker, and he came to our center for an inferior STEMI. So he got his primary PCI done, and then I'll show you directly the angiogram. So as you can see, this is the angiogram from the presentation. He has an inferior STEMI, but also multivessel disease. As you can see, we have this long LED CTO with a clear cap, but with some calcium spots. We have also a tight marginal stenosis, and this is the culprit lesion treated with the drug-eluting stent with some residual thrombus. This is the marginal stenosis, and this is the long CTO with only a septal connection to the distal LED as a retrograde option. So we debated a little bit of this case, STEMI, multivessel disease, RCA done. And we decided to complete the revascularization at the same hospitalization as the guideline says. So our strategy was to begin with the marginal stenting and then go to the LED CTO attempt with the plane A antegrade approach and then plane B as a retrograde from the septal. So we are preparing for two scenarios, and we checked first the RCA. As you can see, the thrombus was gone. And then we were in a single radial with the second radial prepared in case of, and this is the setup shot, as you can see. So we began with antegrade approach. We quickly started with fielder, and it was impossible to cross the cap, although it was clear, but it was uncrossable with the polymer jacket wire. So we escalated to Gaia, and Gaia second did the little path and then buckled. So we escalated to Gaia next 3. We were in La La Land, outside of the vessel. We switched to CP12, and all this escalation led to nowhere. So we decided to not lose too much time, and to switch quickly to a retrograde approach from this septum. So here we are with the second guide. We used our second guide from the second radial. We are in ping pong setting, and we used the Pronavi 1.9, which is a tapered microcatheter, and the sign black. And here you can see we have this connection to the proximal LED. So here we retried some antegrade work with the retrograde guidance from injection from the Pronavi, but it wasn't successful. So we switched quickly to reverse cart strategy. And you can see we tried multiple balloons, multiple inflations, bigger balloons, but it didn't work. So we tried to figure out why. And although we have a good overlap in LED cranial and RAO cranial and LAO cranial, but when you go to this projection of the RAO caudal, you see that both guide wires are very far from each other. Mm-hmm. So when you understand the failure mode, you can switch quick. And here, what we have done, we brought a guide extension to protect the left circumflex ostium, and we worked with the Gaia. We tried to redirect Gaia third next from the retrograde, and finally we could find our path to the guide extension. You can see at the final, when the Gaia connects to the guide extension, there is a little knuckle formed. And finally, we did our connection with the Gaia, and the Pronavi followed to the guide extension, and we were able to externalize NARG3. And given we have dissection planes, we use them dual lumen microcatheter. Here's a Sasuke dual lumen microcatheter, and we can find the guide wire finally found its way to the distal LAD. And we finally got this satisfying result. And we revascularize all the axis of the patient. I prepared for you 2 other cases. I will be a little bit quick. So my second case is a 64-year-old gentleman, also diabetic, but this patient has also coronary artery disease. He was previously stented on his LAD and marginal, and had also 2 non-overlapping stents on his RCA. It was in 2012 and 2016. It was old stents, and he came to our center for an anterior STEMI, which was complicated with cardiogenic shock. So this is the angiogram from the STEMI, and as you can see, there is the culprit lesion was occlusion of the mid LAD at the end of the stent, and it was dealt with implanting a second regulating stent with a good result. Patient then, it was the cardiogenic shock was due to the double jeopardy mechanism, and fortunately hemodynamic situation slowly improved after fixing the LAD, and we were able to withdraw inotropes, and patient was stable with good hemodynamics. And our decision was to complete revascularization, but we have challenges: long CTO, very tortuous, unambiguous proximal cap, side branch rising from the proximal cap, too much tortuosity, and also the collaterals that we can use, the septals, we have to cross a fresh stent, and maybe the septal arises from 2 layers of stent because the second stent was overlapping with the previous one. So this is the setup shot. We are 1 femoral, 1 radial, and as you can see, this is the long CTO with too much tortuosity and 2 stents. So the challenges were as expected. It was uncrossable proximal cap. We have a lot of work to do, trying to bring the knuckle down. We used the scratch and go technique. We tried to use power knuckle, but we weren't successful. But finally, we were successful to progress a little bit with the confianza, but it was clearly outside in the architecture of the vessel, but outside the stent strut. We de-escalated to Gladius and brought a guide extension, and we left things there, and we moved to retrograde. So from retrograde side, we were able to cross quickly the septal to the distal RCA, and when I cross from the stents, I always dilate the stent strut to avoid then my microcatheter to be entangled with the stent struts. And as you can see here, we switched to Pronavi because the Corsair Pro XS wasn't able to do all the path down. So we switched to Pronavi, and we were in the distal RCA. And we weren't able to knuckle also. It was a distal, hard distal cap. And finally, we dealt with the situation. We tried to scratch a little bit with the Gaia and X3, and then did the Carlino, and then finally we were able to have a knuckle in this tortuous path. We were back to the antegrade work. We lost our position, our wire, so we have to do the work again, and finally we were able also to find this the dissection plane and to do reverse cut. And as you can see here, there is the knuckle from retrograde goes up to the guide extension. Here, with Pronavi, we weren't able to cross all the path due to tortuosity and a lot of friction. So what we did was this technique. So it was the anti-grade anchoring technique with a balloon that blocked the retrograde wire, and then improving the support, we were able to bring the Pronavi in the guide extension here. And finally, we were able to secure the final result. This is the final result of the RCA. So if we have time, very quick third case, just to show you a CHIP case. We are in CTO and CHIP meeting. So this is multivessel disease, severe left main, RCA CTO, and as you can see, the RCA which is dominant is taking the collateral from the LED after this severe stenosis in the left main, and there is also a left circ CTO. So this case wasn't for the surgeon. The patient was have a low ejection fraction, and the target of the LAD was diffusely diseased and small, and we have doubts on the viability on the anterior wall. So we decided to fix the distal left main and the RCA. We debated a lot, but finally I decided to begin with the RCA, just like the case presented from the previous speaker. And here crossing wasn't hard. We crossed easily with the regular wire and the microcatheter, but as you can see here, the microcatheter wouldn't follow, and as you can see, the Amplats is backing from the RCA. And here with the Alveo HP balloon, we were able, as you can see, the balloon here is in the distal RCA, and with a little push, it crossed all the lesion, and we are able to dilate the path, bring a guide extension, secure the result on the RCA. We are also lucky, we crossed easily the left circ CTO, and we are able to secure all the access and to have excellent results. So I finish here. So in summary, CTOs are challenging, even though the crossing is simple. Sometimes you have struggle crossing with the device. So we have to fail fast and switch to your strategy quick using the hybrid algorithm. Despite the tortuosity and the angles, Pronav 1.9 was able to cross and we are successful in these two challenging cases. Also, as you can see from the third case, Alveo HP balloon, which has a low crossing profile, was able to resolve this device uncrossable scenario. And finally, when challenging scenario are faced, you have to keep focused and understand the failure mode to resolve it quickly. And thank you for your attention.
Thank you very much for the nice case. It's challenging, I can tell you. But you've done a wonderful job doing the retrograde analysis, crossing over all these occlusions. Any comments from the panelists? Perhaps again, Dr. Hans, any comments from you from China?
Yeah, yes, and thank you for Dr. Aymen, and give us presenting three very, very challenging patients, and especially two of them, and the CTO in combination with the STEMI, and can see, yes, and especially and for the first patients, and my question is, and how long will you stay between the two times PCI procedure, and the first is STEMI for the acute occlusion, and the second time is for the CTO. And how long will you stay keep this patient in hospital? And for the second patient, what do you think of the value of the CTA for the patient for the right coronary artery CTO, and especially when you can't see clearly the parts of the silhouette of the CTO segment, and maybe the CTA can supply some value before this procedure, and for the patient with the CTO, you have used every techniques for the CTO technique, and the ping pong guiding and ipsilateral and retrograde and knuckle sometimes, and so it's very, very challenging patient. This is my question. And for the last patient, this patient has a low ejection fraction and very, very bare rare branch of the LAD and circumflex. Then, and at the same time, this patient has a right coronary CTO lesions, so it's very high risk patient. And but you have the very good result, and congratulations. That's my 2 questions. Thank you.
Thank you, Dr. Hans. Yeah, I totally agree that Dr. Aymen, excellent case, especially when you decided to do that in one sitting, these lesions. I wanted to ask you, what is your the Pornavi, what is the advantage of your Pornavi, since we are discussing these devices, over the other catheters that you've at your disposal? Perhaps you can share with the audience. We've got about 1,200 audience watching.
Okay, so I will begin with answering the question of Dr. Hans. So for the patient who present for STEMI, so usually we don't have problem in the public hospital, so we can keep the patient staying in the hospital. Doesn't bring any problem. So usually we keep them for 1 week. So usually it's 1 week. When they improve and we have to complete the vascularization, we do it after 1 week. And sometimes when the lesion is simple and the patient is stable, and we can bring him back, but before 6 weeks. So we schedule the second PCI when it's simple before 6 weeks. So for the CT, I would love to use it. I had to the CT scan for other scenario when I have an ambiguous LAD osteum. It's useful. Maybe in this scenario, the anatomy, the stance previously placed may explain the anatomy. So the problem was to connect the spaces, to have to bring the knuckles, and not to understand the anatomy, because we have stent placed, so we have an idea of the path of the coronary artery. And to came to the Pornavi microcatheter. Usually I use the Pornavi 1.9 because it has a tapered tip and it has a low crossing profile. So I use it for my majority of the retrograde scenarios. And I find it useful when there is also distal disease. Sometimes when you cross the septals to the RCA with a bigger microcatheter, you can block some distal stenosis, and you make the patient ischemic. So sometimes I withdraw this microcatheter and I bring a Pornavi, which is a very thin microcatheter, and usually the patient tolerates well this crossing, and we have less ischemia.
Mm. Thank you very much, Dr. Aymen. We have a question from the audience. It's regarding a case report that this particular technique, using anchor knuckle technique with the over-the-wire balloon, and not a microcatheter. So they're using an over-the-wire balloon instead of microcatheter, and then you have more support in that way. So, is there any opinion on this in terms of a better way of opening this long-term CTO lesions? Because the comment was that this is probably a better way in terms of getting support for using the anchor knuckle technique for these long-term lesions. Is there any particular advantage you think with a anchor balloon with the anchor technique and over the wire balloon instead of
the anchor technique?
Yeah. So is it over the wire balloon rather than a microcatheter?
When I used the technique, it was just to trap the retrograde wire in the antegrade gear. So I don't think over the wire or rapid exchange balloon would be different. So you have to trap the retrograde wire in the antegrade gear. So you have more support to bring your retrograde microcatheter inside the antegrade gear. So you can you are able after all to externalize your RG3 and to have the loop inside the heart, and you can treat your CTO. That's it.
Right. Thank you very much. Any other comments from perhaps the other panelists? Yes.
Okay, and excuse me, and sometimes for me, and if I do the powered knuckle, sometimes I'm using the balloon to anchor to the side branch, and sometimes using the balloon inside the proximal segment of the CTO segment to anchor the microcatheter to the vessel wall and increase the support. Sometimes it's work.
Yes.
Okay, thank you.
We tried in this case. We tried it. We tried we tried base, power knuckle, scratch and go. We tried all the move the cap technique, but finally we were successful with the scratch and go.
Okay, well done. Right, so we're down to our next speaker for time. We are doing the reverse now. We're doing another Dr. Jorge because of change of schedule because of engagement. Dr. Jorge will go first, then later on will be our Dr. Zhong. Dr. Jorge will now talk to you on port technique with port balloon. Dr. Jorge, over to you.
Hello. Hello.
Yes,
hello. I'm talking from Portugal. Are you listening to me?
yes, of course. Yes, no problems.
Hello.
Hello. Yeah, we can hear you.
Hello.
Yes, Dr. Jorge, we can hear you quite clearly. Hello. You're good. You're
Hello?
okay. Yeah, we can hear you.
Okay. I come from Portugal. So behind me, it's one of the most beautiful lakes of Portugal. So I think you enjoy it. I'm going to present the case. Okay.
Good.
Okay. So, okay. Are you seeing?
Yes, I will see you clear.
Okay. So, this case is not just as complex as the before presented by the before speakers. This is just to see how the particularities of the pot balloon.
Mm-hmm.
So, and the advantage. So, okay. This is the case of a 65 years female with hypertension and dyslipidemia with no previous cardiovascular history, and she was admitted by high risk and STEMI. I'm showing you the left coronary. You can see that there is extension lesion that is going in the initial left main to the LAD. There is a lot of amount of calcium in the wall, like you can see by these scenes. And there is an osteal left main lesion and an osteal LAD lesion as more expressive. The left circumflex, it's without angiographical disease. And I'm not showing here the right coronary, but the right coronary was not with significant lesions, just moderate atherosclerosis of diffuse disease, but not with significant lesions. So I'm going to pass just for the what I do. I prepare the lesion with non-compliant balloons with a 2.5 and a 3.0 balloon, non-compliant balloon from the LAD to the left main. Then I implant a stent, B.R. Friedman stent with 3.0 to 19 of length. This B.R. Friedman has the capacity to expand to more than 5, so I use it just to put it in the small distal LAD to the left main, and then I just put a post dilatation with the pot. I use a pot. I'm going to show you. I use a pot 4.0 from 12 to just have a good pot in the LAD and osteal and the left main and the osteal left main too. And after that, this is the angiographical results. Like you see, I think it's okay. So I put image and IVUS. I'm going to show you the retriever of the IVUS. At your right side is the retriever. You can see that now it's the stent. It's well opposed with no distal dissection. There is a good expansion of the stent. This is the osteal point of the left, and this is the result, like you can see. So the pot is a balloon with a non-compliant balloon with extra short shoulders that reduce longitudinal balloon growth. It's a very low entry and crossing profiles when compared with other NC balloons, and has a ultra low compliance that ensures control minimal growth to the rest blood burst pressure of the balloons without dog bun effects. It's a good balloon to use for optimization of osteal stenting, like this case. It's for accurate post-dilatation and avoiding trauma outside the stent. And it's good for optimization of the pot technique, like I show you in this case. So to take your message, keep in mind that the best stenting patient and the position is the gold standard of the intervention with implantation stent. The right algorithm for lesion preparation, we have to use all that we have to do to prepare calcium and the atherosclerotic wall of the artery. Intracoronary image for guided intervention is better short and have a better short and long-term results. And the pot balloon, before, don't forget it. I doesn't use it in this case, but before it's a good choice to use it. And after stenting for optimization of the pot technique and the osteal lesions. So it's the case. It's very shorter than the before speakers, but I think this is just to show you the particularity of the pot balloon, and like we can use it to improve the optimization of the implantation of stent and the results, short and long-term results. Thank you. I can.
Dr. Rosman, you're muted.
So thank you very much for that very nice illustration of the pot balloon use. Can I just ask, do you find it necessary to image before you plan on? You showed us the image. After that, do you find it necessary to image it to look at the nature of the vessel, the sizing, and so on?
Yes.
How do you approach your lesions?
Yes, in this case I doesn't use IVUS before, but I think it's right to use it. Normally, when I do left main and osteal lesions, I use intracoronary image, and I prefer IVUS in the left main and in the osteal lesions. In this case, I didn't use it before, but I think it was important to use it because we maybe we have a better idea of how to prepare the lesion better, and how to have the right dimensions of the stent to implant it.
Right. Thank you very much. So while we are on that issue. So there are some centers out there who probably don't have IVUS or imaging. So under which circumstances would you feel comfortable about doing the left main without having IVUS? Since because you don't have it or your centers have not got that device available. So in which cases do you think our audience can get by without using IVUS?
Well, if we have an acute coronary syndrome and an ST elevation and an emergent or urgent case, I think we can not use image, and we have to keep the artery. More important to open the artery than use the image. But when it's an elective case, and if we want a better result, we have to use intracoronary image, I think, in the left main, and the complex lesions like bifurcations or anything else, because we have the evidence show us that we have a better long-term results and a better MACE if you use intracoronary image to guiding our intervention in these cases.
Right. Thank you so much. Thank you so much for the comment. Dr. Han, your comment, please. You have something to say now?
Yes, but first of all, thank you, Professor Guardado, and present this interesting case. And it's not very complex patient lesions, but I think because the simpler is the best, maybe. And for patient, this patient is relatively complex lesions because of the orifice of left main is very special point, special location, and has some features for the patient, for the lesions at the orifice. And for this patient, sometimes I don't use the IVOS first, just to using the maybe and choosing a right guiding catheter and advance the guide wire, then using the balloon to predilate it, and sometimes using the cutting balloon to cut to predilate the orifice of the left main, then and check the IVOS and from the LAD and both from the circumflex, and then to evaluate the plaque morphology and the distribution of the plaque, and to measure the diameter of the proximal of LAD and circumflex and left main, then and to make the plan to treat the lesions. And for this patient, using the one stand crossover and using the proximal stand strategy to treat it. And for this patient, and guided by the IVOS, is I prefer using the IVOS tool and over the OCT, and because sometimes the OCT can't see clearly the orifice of the left main, and then using the IVOS and the same, there are several points should be pay more attention to, and because the IVOS and from the circumflex, it's not straight, and it's some angle, and so sometimes you can measure the area of the circumflex, the orifice. Sometimes you can to measure the more large than actually it is. And now, and I have recently, maybe everyone have noticed that there are a new criteria for the circumflex and the orifice circumflex and the orifice of LAD and the left main according to the Park crew, and they give us a new criteria for the left main after the stents, and keeps the areas over 12 millimeter, and the orifice of LAD is 8 millimeter square, and the circumflex 6 millimeter square. And what do you think of using this same criteria to treat all the lesions? Maybe some patients, every patient is different, and they have different BMI, different height, or different body surface, and different reference diameter of the LAD or circumflex. So,
right.
What do you think of this?
Okay, so that's Dr. Han just brought up a point, which is a very, very relevant one in terms of cross-sectional area. Which one would you have any adjustments in terms of cross-ethnic and body types? Do you think that 6, 8, 12 is a reasonable cross-sectional area to adhere to across the board, or should you make adjustments? And can I just ask the panel and the speakers from the faculty? Stick to 6, 8, 12, or you have any other numbers in mind?
I think the cross-sectional is a real number, and we have that always in mind. But I prefer to use the numbers of the stent expansion and the minimal luminal diameter to fix it, the best intervention with IVOS. I like it to keep it simple, and I don't like it to complex the case. So in this kind of case, I think one stent, if it's enough. Of course, we have to do the dimension of the distal point of implantation of the stent and of the left main ostial, and to complete it, of course, the better approach to this intervention. But that kind of numbers could mismatch the best solution and the best intervention of my point of view. We have to use, of course, the best technique to have the best expansion of the stent and the best position of looking always to the plaque composition and to the minimal luminal diameter of the vessel with IVOS. Of course, OCT has a great advantage, but I think in ostial left main, it's not the best tool to use it. Of course, I admit it is a tool with better view of the wall and of the endothelium and all of the characteristics. But with IVOS, we just fix it to numbers. For me, is the minimal luminal diameter and the best and the stent expansion and position.
Okay, thank you very much, Jorge. Dr. ZhanYing, welcome to the faculty again. Any comments, Dr. ZhanYing, if on the last case in regards to the cross surface area? Dr. ZhanYing, are you okay with us? Dr. ZhanYing, your speaker is muted. No? We'll wait for Dr. ZhanYing to sort out his technical. Is that correct? Dr. Zhong Xin?
Okay, I'm here.
Yeah. So I was just about to ask you about your views on the the surface area. Does it really matter in terms of, is it exact numbers you're concerned about, or is it more of the stent in relation to the vessel characteristics that you're more concerned about? Numbers or relationship between the vessel and the stent?
I think the numbers is also the result of some studies. It is not the invention from our mind. It is the result from the amount of patients. So I think the result maybe is not very suitable for all of the patients. In Asia, we'll see there's many patients with a low BMI, but in European and America, there are very large ones. So I think it is not possible to use the same number for these patients. If we want to get a suitable number for these patients, I think maybe we should do some study in these patients with the same BMI or the same size.
Okay,
maybe it's not suitable for all of them.
All right. So thank you very much, Dr. Zhong. So I think the prevailing idea is that maybe it's a combination. You have to look at the numbers as a guide, but also in relation to the vessel characteristics and, of course, the nature of the plaque itself. The most important thing is, of course, the safety of the patient in regards to your results. There is a question from the audience in regard what patient characteristics or lesion types benefit from the pod technique and pod balloon. So I think this is an interesting question, but I think for some audience, this may be an important issue. So Dr. Jorge, maybe you can take that question. the pod technique and the pod balloon? Is it across the board whenever you have this vessel that you need to fully maximize the size, the stent opposition?
I think the great advantage, one of the great advantages of pod balloon is shorter shoulders. It's possible not damage the vessel from distal of when it's distal to the stent. We can just adjust the balloon inside the stent and not protrude it to the distal or proximal of the stent. And it's possible to do a better pod technique. The great advantage of the pod is to optimize the pod technique with this kind of characteristics. Of course, there is another characteristics that it's a great profile, and it's possible to have you can use it a lot of times because it has that kind of characteristics. But in osteal lesions, have the capacity of do the pressure right in that point. And that's a great advantage. It's a non-compliant balloon with its advantage, and the shorter shoulders provide better efficiencies when we are doing the pod technique.
Thank you very much. So pod is principally, yes. You wanted to say something, Dr. Hans?
Yes, I think it's very important using this this balloon and with the short shoulders and to do the pod technique, especially for the left main. It's very short and not too long. The left main, and so using this balloon has some advantage than other balloons.
Yeah, thank you. So the recommendations, of course, anyway, its strength lies in the pod balloon choice is in the left main area where you need to get it to the right size, and you have you want to minimize the amount of stent protruding into the left main area to the shortest possible amount of metal, and then there you use the pod stent in order to maximize the stent opposition and stent expansion. So that's the strength of it. You get very good radial uniform strength and thereby good stent opposition and excellent results. Wonderful. So, right, we'll move on to the next presenter so that we can have enough time for discussion for all of our speakers. So our next presenter will be Dr. Zhong Xin. Dr. Zhong Xin, welcome. And you will talk about optimizing complex lesion treatment and the application of the Wedge NC scoring balloon. Dr. Zhong Xin?
Hey, thank you for the invitation. Let's share. Allow me to share my screen. I'm very delighted to meet you here by the internet. I'm Xin Zhong from the Zhongshan Hospital, Fudan University. The title for me today is the clinical application of scoring balloon. This is the content of my presentation. Here, first, let's see the challenges in our daily practice. Most of us has experienced the below issues in our daily practice. The profile is too big to reach the lesion. The balloon is too stiff to cross. Not good enough to push, and maybe it's not suitable to treat the small or diffuse lesion. Sometimes the balloon is not robust for the hard lesions. For example, the calcification lesions. These issues maybe occurs every day for us. So, how could we treat this? Treat these ones? The weapons in our hand actually is not limited. We have conventional balloons or high pressure balloons. These balloons can help us to treat the lesions, most lesions in our daily practice. But these all have some limitations. In addition, we have cutting balloons. Actually, the cutting balloons helps us a lot. It is designed for the mild or moderate calcified lesions of further preparation following ROTA. But we could see some problems. For example, in some severe calcified lesions, the expansion is not satisfied, and if we dilate with excessive pressure, there is a risk of place locked. It is a disaster. In addition, in some patients, the cutting balloon is not difficult to reach the target lesion. So the cutting balloon has its own problems. Today, we have another weapon, the scoring balloon. Scoring balloon, in my experience, if the cutting balloon cannot cross the lesion, the scoring balloon, I use the scoring balloon to cross the lesion. The success rate is very high. The fundamental of the cutting balloon relies on the wire fixed on the surface of the balloon. It can transmit the force through the external wire to the block, so we can gain the lumen, enough lumen size even with a low pressure. So this is the Bosmed scoring balloon. It has more profile, good crossability and pushability. We can use it just like a conventional balloon. Next, let's see the technical specifications. This is the design of the Wedge NC balloon. The proximal shaft of the balloon canister is 2 French. The distal part is 3 French. There is a nickel titanium wire fixed on the surface of the balloon. It is linked from the tip of the canister balloon to the distal shaft of the balloon. So it is a central part of this balloon. The balloon fixed on the surface of the wire fixed on the surface of the balloon allows a good expansion in the longitudinal direction in the lesion. So we can reduce the risk of the injury of the vessel. Meanwhile, we gain enough lumen size. We can see the picture. The wire is designed to longitudinally fracture the block at a low inflation pressure. So the injury is also limited. From this picture, we can see the tip of the wedge balloon is tapered. So it has good crossability in the lesion, and meanwhile, it can reduce the damage to the vessel. This is a comparison of compliance of the serial balloons in our daily practice. We can see the curve of the Wedge NC balloon is more smooth than other competitors. This can reduce the risk of complications such as vessel dissection and vessel perforation. From this table, we can see the nominal pressure of the Wedge NC balloon is 12 atm, and the RBP is about 22 atm. Actually, the average burst pressure is over 30 atm. So the Wedge NC balloon is a real high pressure balloon. It allows us to dilate it with a very high pressure. The size of the balloon is also can meet our need. The diameter of the balloon ranges from 20 to 50. The length of the balloon ranges from 6 to 30 millimeter. So it is reliable in our daily practice. It is not limited about the size. This is the comparison of the size of the series balloons mentioned above. We take the 3.0 balloon for example. We can see the size of the Wedge NC balloon is the smallest among them. This is the visual visual comparison of the serial balloon, we can see from the table to the body of the balloon, the Wedge balloon all have a good performance compared to the other competitors. The Wedge balloon have many advantages. It allows us to have a good, precise, safe, and orderly dilation. Meanwhile, we can reduce the risk of dissection and have a good ideal vessel preparation. The post-med Wedge balloon is ideal for the instant stenosis lesions and moderately calcified lesions. It can reduce the incidence of doggy bone and slippages of the balloon. Part 3, let's see some clinical evidence. This is a feedback from the physicians. We can see, compared to other competitors, the feedback from the physicians is also very good from the delivering and the crossability and so on. So, in our daily practice, the Wedge balloon is a very good tool for the serial of hard lesions. This is a study which compared the Wedge balloon and the Scoreflex balloon. From the technical issues to the clinical events, we can see the Wedge balloon have the comparable results with the Scoreflex balloon. So it means it is a good tool for our daily practice. Last, let's see some clinical cases. Case 1, the Wedge in classified lesions. This is a male patient, 59 years old. He was admitted to our hospital for recurrent chest pain for 1 week. From the color angiography, we can see a diffuse calcified lesion from the left ventricle LAD with diagonal 1 involved. This is a long lesion. Initially, we chose the 2-0 balloon, a conventional one, but the dilate is not very good. Even for many times, it is not sufficiently. So we initiated the ROTA. We chose the 1.5 bore and 160,000 RPM. After about 4 times rotation, we cross the lesion. Then we do the iris. The iris showed the calcium range was derived after the ROTA. Let's see. But in some parts of the lesion, the expansion maybe is not very enough. So we firstly chose 2.5 Wedge balloon for the lesion modification, and the dilation is satisfied. This is the result. We treat the lesion from the left ventricle LAD with 2 stents and diagonal 1 with a DCB. After the post-dilation, we rechecked the iris. the result showed a good expansion of the stents. This is the final angiography of this case. Okay, this is the first case. The next case is Wedge NC in small vessel disease. The patient was male, 64 years old. He has recurrent chest pain for 6 months. From the angiography, we can see 2 limited lesions in the PD and PL. 2 lesions. We chose 2-0 Wedge NC balloon for the PD, for the lesion in the PD, and the predilation is good. Then we treated this lesion with a DCB. The same, we chose 1-0 Wedge NC balloon for the lesion in the PL. This is the result after the predilation. It's very good. So we also choose the DCB for this layer. This is the last result of this 2 layer. The next case is Wedge NC CTO PCI. The patient was male, 78 years old. He was admitted to our hospital for recurrent chest pain for 2 years. The angiography showed CTO lesion in the right coronary artery, in the middle part of the right RCA. This is not a very difficult one. So we chose the COSAM with a XT wire. Unfortunately, the first wire is not correct. So we initiated the parallel wire technique. During this phase, we tried guide third and pilot 200 wire. At last, the guide third entered the distal lumen. However, even with the extension catheter, the predilation is not very easy. We start from 1-0 to 1.5 to 2-0 balloon, and with the extension catheter and the predilation, we finally cross this lesion. For a good lesion modification, we choose a 2.5 Wedge NC balloon to dilate this lesion. After 2 stents was implanted, the result shows a good expansion of this lesion. This is the result of this case. We have many benefits from the Wedge NC in complex lesions. It can facilitate the dilation of some hard lesions, for example, the calcified lesions. It can achieve effective and orderly expansion along the direction of the blood, and it can reduce the injury to the vessel. It can achieve an ideal lumen gain, meanwhile preventing the suboptimal stent implantation. The final aim is reducing the incidence of TR, improving the long-term of outcome. It can help us. Thanks.
Thank you very much, Dr. Zhong. Dr. Hans, perhaps we can invite some comments before we open it up to the rest of the faculty on this very interesting case about the use of the scoring balloon. This is indeed a very new and exciting development, this class of balloons, because it enables us to use this balloon for small lesions, very distal lesions, as seen in that very nice case of the distal RCA. So this is the sort of case that we're starting to see, or beginning to see for some time now, in many of our patients in Asia. For your comments, Dr. Hans, in regards to the use for this scoring balloon.
Okay, and for these several cases presented by Dr. Zhong Xin, and I have learned about a lot of more, and especially for this balloon, and has very excellent crossability for the lesions, and I think if you choose the CB cutting balloon, so there's no so excellent crossability, and especially for the lung, for the lung diffuse lesions, and sometimes we have very mild to moderate calcification, and you can use this scope balloon to predilate the lesions, and for this and for several cases and presented by several doctors, and because for the I have some comments for these cases, and because of the remarkable progress has been achieved for the treatment of CTO lesions, especially for the patient with CHIP. So just such as the Wedge NC balloon and the pronary microcatheter, especially, and I just mentioned the alveolar high pressure balloon, and with very lowest and profile, and then can give with a very high pressure, and sometimes for the patient, for the lesions, it's very difficult to advance the small balloon, and even you successfully advance the balloon to the locator of the calcification, then and just at the beginning of the predilation, and the balloon will rupture. Then it's very disappointed. But now we have the alveolar high pressure balloon, and it has the very crossability and very small and profile. Then you can advance this alveolar balloon with just the diameter is 0.75 millimeter. Then you will have the very high pressure to predilate it. Then and make some chance for the following treatment of the lesions. So just so. Okay.
Well, thank you very much, Dr. Hans. So you've seen how these catheters and the balloons have been in use. Can I invite some comments from the faculty about the general in cases that you've seen so far, from the first case by Dr. Ajit down to the last case here by Dr. Zhong? Anything that you would feel is important, especially in regards to the devices that we've discussed, the wedge balloon, the LVO, SC, but like an high pressure SC balloon, then your pronary catheters, and of course your scoring balloons. Any comments?
I can start.
Yes, of course.
About the scoring balloon, I treat a lot of patients with calcium. My center is one of that in Portugal more do with rotational atherectomy, orbital atherectomy, and calcium patients. I have a scoring balloon in my scenario, not this one of Rosman, but sure I'm going to have it in my Unity. Of course, the scoring balloons it's a tool, a very interesting tool for distal lesions, for lesions with the calcium that we cannot have easily dilated with non-compliant balloons, and for restenosis too. I think it's a wonderful tool to apply when we have a localized lesion or a small extension of calcium, and that is important to do a great and a good dilatation and the modification of the plaque without a great extension. If you have calcium in all of the extension, it's better to use another kind of tool like atherectomy, rotational or orbital or something else. But these scoring balloons, it's a wonderful tool for some kind of patients, and it's important to have it in the arsenal of the calcium treatment.
Thank you. I totally agree. And I think we are increasingly using it not just for distal, but also for osteal lesions. Can I get your opinion, Dr. Aymen, for the use of scoring balloons in osteal lesions? Sometimes they say it's perhaps better because you get a controlled dissections to use it in the osteal setup, so that there's less of a surprise. What is your view on that? Or do you feel that you should start with a perhaps semi-compliant and move to non-compliant? And what is your preference for osteal lesions? Would you default straight to a semi-compliant, or depends on your characteristics of the vessels, Dr. Aymen?
Thank you for your question. Usually for osteal lesion are challenging scenarios. There is a lot of fibrotic tissue, so it's hard to overcome. I usually never use semi-compliant in this scenario. I start with the usual non-compliant balloons, well-sized. And then when I prefer the scoring balloon, I had the Wedge NC in my cath lab. So I use it when I have this watermelon seed effect. When you inflate your balloon and your NC balloon slips through the lesion, and you don't apply much pressure on the lesion. Usually, I switch to Wedge NC or and it works.
Okay.
In some difficult scenarios, sometimes I use also when it doesn't work, I use OPN balloon. I have OPN balloon in my cath lab, and I keep it for the most challenging scenario.
Right. Thank you so much. So the OPN balloon is a very high pressure balloon, as you all know. Dr. Zhong, can I ask your view about the use of your scoring balloons in regards to calcified lesions? You mentioned the use in moderate lesions. What is your endpoint when you use this balloon in calcified lesions? Do how much of an expansion do you look for? What tells you that you've done enough? How many inflations are required? And what is your average number of inflations for your lesion, for example, on this moderately calcified lesion? Could you tell us a bit more about how you differentiate and decide on these lesions to be with a scoring, or perhaps even with a rotablation or orbital arterectomy?
In my opinion, I will choose optimal size of the balloon to check if the expansion is sufficient. Maybe I really will not choose the same size with the vessel. Maybe I think it's a little smaller than the real size of the balloon. Maybe suitable for this calcified lesion. Maybe 1.8 about this scale of the real size of the balloon. It can be dilated, satisfied. I think the expansion is good. Of course, I will use we will not use the conventional balloon. I will choose the scoring balloon and the cutting balloon to treat this one. And after this, we will check if the expansion is good.
Right. So you're suggesting that, if I heard you correctly, is that you choose a slightly smaller size scoring balloon so that you can go to higher pressures. Is that correct?
Yes.
Okay. So that's a good point, because I think this balloon, the Wedge, is able to go up to beyond 20 and even up to 30 based on the technical specifications. Is that right? So that's a very high pressure indeed. Right. So I invite any comments from the audience in regards to any of those cases, since we are close to closing time already, 5:30. Does anybody have any final remarks in regards to the sort? Can we start with you, Dr. Ajit, since you started the first case? Any comments, final parting words on the case that we've discussed? Is Dr. Ajit with us? Okay, maybe Dr. Ajit's offline. Dr. Aymen, first, second.
Yes, I would like to thank Rosman for the invitation. It was very interesting cases and good to share experience from all over side of the world. I don't have any other special comment. Thank you very much.
Okay, thank you very much. Dr. Han?
Thank you for several doctors to present excellent cases for us. I have no other comments. Thank you.
Thank you. Dr. Jorge, your comments from lovely Portugal, enjoying the fitness background.
Well, it was a great pleasure to have with you in this session. Was an excellent panelist and excellent cases and a top discussion about this kind of issues of complex intervention and the use of devices. And a special thank to Rosman to invite me to this appointment and this reunion international with a lot of people. So from Portugal, I just have to thank you to all of that participated and share his opinion and comments with me. Thank you.
Thank you, Jorge. Dr. Zhong?
Thank you very much. No more comments from me.
Thank you very much. So which brings me to give the final roundup, which is basically number one to mention that make mention of the fact that we've had several excellent devices being showcased today. Well, the first, of course, is the LVO, the balloon, which is unusual in that it can behave as a high pressure semi-compliant balloon with very little percentage, goes of about 10%. And of course, you've got the ProNavi catheter, which is able to track very distal lesions, has got good crossing profile. You've got the Wedge catheter, which is wonderful in terms of its ability and crossing profile and high pressure performance from 20 to up to 30 atmospheres. And these are all very important devices that we should use in our patients. So I'd like to thank Rosman for their wonderful, and of course the pot balloon, before I forget the pot balloon, which is very, very important for use, especially in the left main scenario where it gives you that comfort in achieving high pressure, but at the same time minimizing the barotrauma to the normal section or non-stented segments. We've had a discussion about the current approaches to tackling these lesions in terms of surface area discussion, as well as the approach to distal calcific lesions and modifying the calcium burden on the plaques. So I'd like to thank Rosman and all those who have been involved in organizing this and for giving me the opportunity to chair this session with all the wonderful and distinguished faculty and the exciting discussion that we've had and the very good case presentations, very good learning points. And I'd like to thank all the audience for being with us this afternoon. Many, I think, over in excess of 1,200 individuals, as I mentioned earlier on. I'd like to wish you all a very good week and thank you very much once again for being here with us. Thank you, everyone. Bye-bye.
Thank you so much.
Thanks to every expert.